invite our next speaker on the stage, ladies and gentlemen, we have a few announcements. We have a guided poster tour scheduled tomorrow at 8:30 in the morning.
There's also a makeshift daycare in Henna Hall from 9 p.m. to 5 p.m. They're here today as well as tomorrow, and it's basically supervised fun for kids with movies and a play area. I would also like to remind everyone that the Q&A session will be held right at the end of the session after everyone's talks.
Ladies and gentlemen, our next speaker is a consultant rheumatologist and associate professor currently working at the Fauji Foundation Hospital in Rawalpindi. He has been an active member of the College of Physicians and Surgeons Rheumatology faculty for the last 6 years.
He remained the General Secretary of the Pakistan Society of Rheumatology from 2017 till 2020. He has numerous publications and has even written 2 books. Please welcome Dr. Babur Salim onto the stage.
Assalamu alaikum. Thank you very much for the very kind introduction. And indeed, it's the privilege to give a talk in front of the legends, both national as well as international. Well, the topic I have been given is, I'm sorry, I've got a restless leg syndrome, so I won't be standing here. So it's very difficult for me to stand on the podium, and so I'll be roaming around. So the topic I have been given is the rheumatoid arthritis, a year in review. It was a little bit difficult, so whole of my presentation is going to be relying between the EULAR 2022 recommendations and something from the Novel Insights from 2023. Well, I did my search from the PubMed indexed journals, and most of them had the clinical trials and meta-analysis. And after writing the rheumatoid arthritis treatment, and between 2022 and 2023, I got 397 results. And so it was nearly impossible to cover the 397 publications right away in 20 minutes. So I'll be excluding the following things. I won't be talking about the comorbidities, vaccinations, some novel drugs, biomarkers, new data related to musculoskeletal ultrasound, and biosimilars in rheumatoid arthritis. And after that, excluding them, I came to 97 results. So my presentation is predominantly relying on these 97 publications. So out of these 97, the most common topics which were close to my heart, and I might be missing some, I'm really sorry, but these were the common ones out of these 97 which I've chosen. I'll start with the first very common topic, that is the preferred route of methotrexate administration. Should we go for an oral route or should we go for the parenteral route? Well, let's see some data. We still know, and this has been dictated in all the recommendations, that methotrexate is by far the first line medicine, and recently published in EULAR 2022 recommendations as well. But as per the EULAR 2022 recommendations, they have not addressed the preferred route of using the methotrexate. Should we go for an oral or should we go for the parenteral methotrexate? So let's see some data. This is the systemic literature review from the PubMed, and out of 705 trials, almost 6 met the inclusion criteria, and it was around 644 patients, and they found that oral methotrexate at a dose of 15 to 25 milligram in active rheumatoid arthritis is not at all inferior to parenteral methotrexate, both in efficacy and safety. So we have the choice. We can go for oral or parenteral. It's the physician's choice. So the second hot topic is the new remission criteria for rheumatoid arthritis. Well, this is the previous remission criteria by the Boolean and by Joseph Smolin, published all in 2011. And this was a very stringent criteria. If you see that everything is 1 or less than 1, the patient must have a swollen joints of 1 or less than 1, tender joints, CRP, patient's global assessment. So as per the American College of Rheumatology, this is the revised criteria published last year, and they have made it less stringent by increasing the patient global assessment from 1 to 2. And what they have found was, by increasing the patient's global assessment, the number of patients increased more, they became more into remission, from almost 14% to 20% in early rheumatoid arthritis, and from 4% to 6% in established rheumatoid arthritis. And the important thing was, without the compromising on the radiographic progression and health assessment questionnaire scores. The third hot topic, which I found in the last 1 year, was the repeatedly coming again and again in different meta-analysis, was that methotrexate route of administration, does it have any effect on the relapse or the flare? And the data basically comes from the TARA trial. And what they did was that after the shared decision between the physician and the patient, the patients who were on sustained remission, their methotrexate was tapered. That was 2.5 milligram after every 3 months. Half of the patients were on subcut methotrexate and half of the patients were on oral methotrexate. And they found that the more relapse rate, more flare rate was found in subcut methotrexate as compared to the oral methotrexate. They could not find the reason, but the authors concluded that should the route of administration of methotrexate be considered when reducing the methotrexate dose after the shared decision. The fourth hot topic is pre-rheumatoid arthritis. Should we really treat them or not? Well, this is the data from the Treat Early study, which included almost 236 patients. And they include those patients who had arthralgias and they did not have a clinical inflammation. They did not have any clinical evidence of synovitis. They only had MRI-detected subclinical inflammation. So half of the patients were given methotrexate and half of the patients were given placebo. And they wanted to see, and after 1 year, what happens to the patient. And they found that the arthralgias, pain, morning stiffness, HAQ scores, MRI-detected inflammation, all improved in the methotrexate group. But unfortunately, methotrexate was not able to prevent rheumatoid arthritis onset. So we still have a debate that should these patients be treated or not. We do not have any recommendations on this. The fifth hot topic is the predictors of response to treatment. We already know that there are certain predictors. For example, the patient who is seropositive, they sometimes respond well to rituximab and TNF and abatacept. Similarly, those patients who have high acute phase reactant, they also sometimes respond well to certain biologics. Well, this is something beyond these. This is the North Star trial. This is a post hoc analysis. What they did was, there were almost 800 patients and 200 in each group. One group had the conventional synthetic DMARDs and then the rest of them had different biologics. And they found that the remission was high in all the patients who were male. So they predicted that probably higher remission rates were observed in men. So they believe that gender may be an independent predictor of response to RA therapies, whatever the therapy is. Furthermore, this is the multi-center cohort study published this year. They found that failure to start methotrexate within 3 months and not being off the steroids for within 6 months they are also predictive of that these patients will later develop difficult to treat rheumatoid arthritis. And this is one of the reasons that all the recommendations is that you need to taper the steroids within the 3 to 6 months, apart from the side effects and intolerance with the steroids. So take-home messages so far from the 5 hot topics is that oral methotrexate is not inferior to parenteral methotrexate. Boolean 2 remission criteria can predict more remission as compared to Boolean 1 without compromising on the radiographic scores. Parenteral methotrexate tapering has more relapse as compared to the oral methotrexate. Treating pre-RA may improve symptoms but does not prevent the onset of RA. And female gender administration of methotrexate after 3 months and steroids tapering after 6 months may predict that these patients will later on develop difficult to treat rheumatoid arthritis. The next 6th hot topic is that first biologic failure. What should be the next plan of action? Should we move on to the biologic with a different mechanism of action, or should we jump onto the biologic with the same mechanism of action? Well, the answer to this basically comes from 2 major registry. One is the BSR biologic register. The data, the online data available is from 2001 till 2020, and the next registry is from the United States, that is the Corona registry. Briefly about the British biologic register is that it has almost 23,000 patients who are on biologics and targeted synthetic DMARDs. And if you see that this is the first one, the second, almost 23,000 patients are on biologic or targeted synthetic DMARDs. Half of them fail and they jump onto the second biologic or a targeted synthetic DMARD, further half of them fail and they move on and on and on. And if you see the difference, if you see the orange bar, that first biologic or the targeted synthetic DMARD, irrespective of the mechanism of action, shows the best result, that is around 17%. And after all, then second, third, fourth, fifth, all have almost the comparable results. These were the data was the same as received from Corona Registry from United States, that no significant difference in achieving low disease activity at 1 year between TNF and non-TNF after the failure of the first TNF. So cut short story is that EULAR recommends that there is no preference between switching or cycling with the same mechanism of action. So if your patient fails with the TNF, you may jump onto the TNF as another TNF. It's not that our heart says that let's jump onto a class switching, but the data so far suggests that there is no add-on difference between switching or cycling. The seventh hot topic is biologic and targeted synthetic DMARD. Should we be using them with conventional synthetic DMARD, or we can use them as a monotherapy? Well, if you go back to 2022 recommendations, biologics and targeted synthetic DMARDs should ideally be combined with conventional synthetic DMARDs, but let's see some head-to-head trials. You won't be going into all the details of all these head-to-head trials, but just the first two, ADACTA trial and Monarch trial, they were basically done to see the superiority of the IL-6 inhibitors. The first one was for tocilizumab and the second one was for sarilumab, and they found that they can be used as a monotherapy. And similarly, this is the SELECT early trial to see the efficacy of JAK inhibitors, to see that they can be used as a monotherapy or not, and the answer was yes, they can be used as a monotherapy because it achieved all their primary outcomes, including ACR 20, 50, 70, and DAS 28. So the nutshell, the EULAR recommends that IL-6 inhibitors and targeted synthetic DMARDs can be used as a monotherapy compared with other biologics. Then there's the efficacy of JAK inhibitors versus biologics. I won't be going to the detail because everything is, they both have been FDA approved prior to 1 year. The topic I have to cover is just 1 year. So baricitinib got its FDA approval on the basis of all these BUILD, Beacon, Beam, and Balance trial, and abatacitinib got its FDA approval from all these SELECT trials. This is the FINCH 1 and FINCH 3 trial for filgotinib, which is yet not FDA approved for rheumatoid arthritis. It has recently approved for inflammatory bowel disease. It has also shown that it also slows the progression of radiographic progression in rheumatoid arthritis. So coming back to the efficacy between JAK inhibitors and biologics, this is the data from the 19 registries, that is the JAKPOT collaboration, and they found that it has almost 31,000 patients, and most of them were on TNF, followed by JAK inhibitors, and then IL-6 and abatacept, and they found that the remission and low disease activity both were equal in almost all the group except in abatacept. So the EULAR recommends that if there is a failure of the first conventional DMARDs and the patient has poor prognostic factors, biologic DMARDs should be added. There's no doubt about it. However, JAK inhibitors may also be considered pertinent to the side effects. We need to know the side effects, which I'll discuss later on. This is the next topic that, for example, if the patient, your targeted synthetic DMARD has been failed, I've added this because so many pharmaceutical companies are coming to us and they have a plan to bring baricitinib and abatacitinib in 2024. So that is the reason I added this point, that if our patient does not improve with the targeted synthetic DMARD, what should be our next plan of action? Should we do cycling to another targeted synthetic DMARD, or should we switch to a biologic DMARD? Well, the data again comes from the JAKPOT collaboration, and as per this, the cycling and switching were equally effective in improving the CDAI scores. However, the cycler faced almost the same side effects which were encountered with the first JAK inhibitor. So if I take as an anecdotal experience that if my patient does not improve with JAK inhibitors, I might jump onto a second JAK inhibitor if I don't have any other choice. But if my patient has some kind of serious side effect with the first JAK, I'll rethink of giving the second JAK, should I go for it or not. So take-home messages till now, till the 9 hot topics, were that after the first biologic failure, no preference was reported between switching or cycling. IL-6 and targeted synthetic DMARDs can be used as monotherapy. Failure after first conventional synthetic DMARD with poor prognosis, biologic DMARD should be added. However, JAK inhibitors may also be considered. After JAK inhibitor failure, cycling and switching are equally effective. Well, this is the last hot topic, is the targeted synthetic DMARD and biologic safety. I'll just talk about the latest last 1 year data regarding the infections which were so much highlighted regarding herpes zoster and tuberculosis and malignancies, TNF versus JAK inhibitors, and cardiovascular risk events with certain medicines. Well, this is the data from the Rabbit register, which includes almost 14,000 patients. Out of these 14,000 patients, almost 559 patients had herpes zoster. And if you see, the maximum exposed adjusted event was with JAK inhibitor, which was around 21.5, and followed by rituximab. And after that, all the biologics had almost similar effect on having a herpes zoster infection, and the least was seen with conventional synthetic DMARD. And as per the Rabbit register, it was concluded that 3.6-fold increased risk of herpes zoster associated with targeted synthetic DMARDs, followed by other biologics as compared to the conventional synthetic DMARDs. Tuberculosis, unfortunately, Pakistan ranks the 5th amongst the high disease burden. This is the data from the WHO presented last year. And we all know that there is a slight risk is more in rheumatoid arthritis as compared to the general population, which is around 2.28-fold. And this is the data to show the risk of tuberculosis between biologics and versus non-biologics. It is a meta-analysis which included almost 39 studies and included almost 20,000 patients. And out of these 20,000 patients, 82 patients had developed tuberculosis, and they found that the risk of tuberculosis was increased in patients who were treated with biologics as compared with non-biologics. And the TB risk was also compared among the different biologics, and if you see that the maximum risk was with infliximab, and after that, although we can see that etanercept has the least risk, but the values were not statistically significant. So the risk of tuberculosis among the different biologics was almost the same, except infliximab. Malignancy in RA, and this is the data from the oral surveillance trial 2023, and this has almost 4,300 patients, and the survey was done over a period of 7 years, and they found that there is a 3.8% reported malignancies, and they excluded the non-melanoma skin cancers, and the most frequent malignancy they found was the lung cancer, which was reported around in 1%, and was seen maximum with the TOFA group as compared to the TNF. And this is a very interesting graph. If you see the orange arrow, if you see that the risk of malignancy between the JAK inhibitors and the TNF was similar till 18 months. But after 18 months, if you see that the probability of not having a malignancy was more in the TNF as compared to all the groups of JAKs, which means that probably the risk is time dependent, because so many more studies came after this oral surveillance trial, and they said there is no risk of malignancy with tuberculosis, and there was one thing in common in them, that they were not time dependent. All the studies was like 1 year, 2 year. So the risk increases as long as the duration of uses is increased. Similarly, this is the hazard ratio with comparing the JAK inhibitors with the TNF, and you see that if you compare, the hazard ratio is more with the JAK as compared to the TNF. Similarly, the incidence rate with all the TOFA groups is high as compared to TNF. Cardiovascular risks, some known facts. We already know that those patients who are seropositive and have higher disease activity, longer disease duration, they have more prone to have some kind of cardiac event. But I'll go a little bit beyond that. This is the 2023 data for JAK inhibitors. They compared the risk of cardiovascular event between JAK and between TNF, and they found that, and the patients were followed up for a period of 4 years, and they found that the hazard ratio for all the cardiovascular event was clear-cut high in the JAK groups as compared to the TNF. And this is the incidence ratio. All the groups of patients who were taking TOFA had slightly more risk of cardiovascular event as compared to the TNF. So this is my last slide, that the take-home message is there is a 3.6-fold increased risk of herpes zoster infection associated with targeted synthetic DMARDs. Risk of tuberculosis is more with biologics compared to non-biologics. Incidence of TB was same among different biologics except infliximab, and hazard ratio and incidence risk for malignancy and cardiovascular event is higher with JAK as compared to TNF. Thank you very much.